I'd like to welcome to the stage and to Canberra Dr Linton Meagher. Dr Meagher is a neuropsychiatrist from Sydney, where he did his medical degree with honours from the University of Sydney, then trained at the Royal North Shore Hospital and completed a Master of Psychiatry along with a post-fellowship accreditation in the subspeciality of consultation liaison psychiatry. He might tell us what that means. Linton was awarded an Institute of Psychiatry Fellowship and Young Investigator Grant from the Royal Australian and New Zealand College of Psychiatrists for his specialised training in neuropsychiatry, focusing on I'm getting very tongue-tied here, neuropsychiatric morbidity associated with deep brain stimulation in Parkinson's. Parkinson's is a key focus of his private practice in Cremorne, along with his work as a visiting medical officer with DBS at North Shore Private Hospital. He's also the Assistant Director of the Mood Disorders Unit at Northside Clinic. Dr Meagher actively participates in research and teaching and is a clinical associate at the University of Sydney. So, more than well qualified to talk to us today about the Parkinson's blues. Welcome, Dr Meagher.
Okay, well, thanks everyone. And firstly, look, I think a lot of work has gone into this from the volunteers. I've had a lot of dealings with Marcia and others. So a lot of people have volunteered their time, and I'm very happy to volunteer my time. And I think Parkinson's Australia and grassroots community support organisations for Parkinson's are really pivotal. I've done some talks for Parkinson's New South Wales, so it's great to actually be in Canberra. And I'm going to be focusing on particular aspects of the non-motor symptoms. We have to talk about any conflicts of interest. And the only relevant conflict of interest is that I'm involved with the Parkinson's DBS group in Sydney. And we're going to be talking about neuropsychiatric symptoms. So that's the overlap between neurology and psychiatry. And Parkinson's disease is very much the quintessential neuropsychiatric condition. And the symptoms that we refer to as neuropsychiatric symptoms, they can be due to the changes in the brain itself, they can be due to emotional reactions to the disease process, or they could be due to treatment-related side effects, such as from medications or from other interventions such as deep brain stimulation. So these neuropsychiatric symptoms incorporate a number of different things, including depression and non-motor fluctuations, anxiety disorders, hallucinations and psychosis, disorders of sleep and wakefulness, mania and a milder version of mania, which is hypomania, cognitive impairment and dementia, apathy, impulse control disorders, and associated syndromes such as punding or dopamine dysregulation syndrome. So we're going to be focusing just on the first three today. The other aspects are talks in themselves. And a really important thing to flag, as has been highlighted earlier, is that depressive episodes or panic attacks precede the onset of motor symptoms in up to 30% of patients with Parkinson's. So the way we think about symptoms such as depression and anxiety has shifted, and we see that they're very much a core feature of the condition. And so historically, a lot of the focus has been on motor symptoms, but we actually now know that the main source of disability, particularly as the condition advances, is actually the non-motor aspects of Parkinson's. And more importantly, if we can better treat the non-motor aspects of Parkinson's, we can actually improve motor control. So for example, by treating an anxiety disorder, treating a mood disorder, we can actually improve motor symptoms. So neurologists have cottoned on to that, and I work very closely with neurologists to jointly manage some of these things. And I'll talk about how that overlap works in practice. This is a slide that it's a bit of a busy slide, but what it shows is the concept of normodopaminergic behaviour, so behaviour that's within a normal range of dopamine, and then what happens if we have too much dopamine on board or too little dopamine. So in the blue there you have motor symptoms, so when there's too much dopamine we experience dyskinesia, but also from a non-motor perspective we can experience increased mood, a relief of anxiety, euphoria even, and manic-like behaviours. Then in the hypodopaminergic state, down the bottom, when there's too little dopamine, we can experience reduced movement, rigidity, and in terms of non-motor symptoms, we can experience apathy, low mood, and anxiety as well. So this idea of non-motor fluctuations is very important, along with thinking about motor fluctuations, and I'll come back and talk more about that. So just talking first about depression, and I should point out I'm making these slides available as well. So there's a bit of information in some of these slides. Some people may want to dip into different levels, but if you want to have a look at these slides, I'm happy to make these available. So depression is extremely common. As we mentioned, it's for a third of patients, it's the first symptom they get of their Parkinson's. But about 35% of patients will have clinically significant depressive symptoms. And depression in Parkinson's leads to a decrease in quality of life independent of motor deficits. And it's important to emphasise that depression is not directly related to motor impairment. So someone can have very mild impairment and very severe depression. And similarly, someone can have very severe motor impairment and not experience depression. So it doesn't correlate. It's a separate issue. And it very commonly occurs along with an anxiety disorder. So it's more common than not, 65%, that people who experience depression, a major depressive episode, will also meet the criteria for an anxiety disorder. So what are we talking about when we talk about major depressive disorder or a major depressive episode? We're talking about a syndrome that's present for more than 2 weeks. So it's normal to experience distress, to be sad at times, but it's different if we're depressed more days than not for more than 2 weeks. But it has to be accompanied by a cluster of other symptoms, and these include difficulty getting pleasure from things that previously would have given us pleasure. That's what we refer to as anhedonia, a change in sleep, guilty ruminations or worthlessness, loss of energy, poor concentration, change in appetite, and psychomotor retardation or slowing down of the motor system, or in some people speeding up of the motor system, psychomotor agitation, and suicidal ideation. Now, to complicate things, in Parkinson's, some of these symptoms can be physical manifestations of the disease. So these are the criteria that we use for people in the general population who don't have Parkinson's. And complicating this is that things like sleep, energy, appetite, psychomotor retardation, they can all be features of Parkinson's. So you'll see a variation in prevalence, and there's a bit of a debate about how we should, there's a bit of a debate about the criteria that should be used to diagnose depression in Parkinson's. But we're going to be focusing on depression or melancholy, and this is about as exciting as this talk gets. The slides are all pretty boring from here on in. So one thing that's really important with thinking about depression is that with Parkinson's, historically there's been a lot of focus on loss of neurons in the substantia nigra, so dopamine-producing neurons. But as we've learnt more about Parkinson's and the degeneration, how it proceeds over time, we realise that the loss of neurons doesn't only occur in the basal ganglia. So there's loss of noradrenergic neurons in the locus coeruleus. There's loss of serotonergic neurons in the raphe nucleus. So neurons that are involved with the production of serotonin and noradrenaline. And it's been shown that there's more marked degeneration in Parkinson's patients with depression compared to those without depression. So this is a really important concept. So as much as we think about trying to modify the neurotransmitter balance in the brain by using dopamine, we need to think very carefully about the role of something that might modify serotonin and noradrenaline. And we'll talk about this when we focus on antidepressants. But this is a really important concept, and it's shifted the way we think about managing those non-motor aspects, and it's led to a much lower threshold for recommending antidepressants or other strategies to target depression. But when we think about depression and anxiety, they're complex conditions that have a number of causes, and there's still more we need to learn to understand all of those factors. But there's biological factors that are relevant, there's psychological factors that are relevant, there's aspects of that person's social situation and lifestyle, which can all contribute. So when we think about trying to manage depression or manage an anxiety disorder, we really need to have a holistic approach that addresses each of those factors. And we need to think about things that might predispose to a mood disorder or an anxiety disorder, and we need to think about things that can precipitate or perpetuate the situation as well. So in terms of practical steps to manage depression in Parkinson's, the first thing is obviously to ensure safety. And then, once we've addressed the issue of safety, then we need to exclude or treat possible physical causes of depression. So that includes a really good physical examination. It's important to have comprehensive blood tests, including looking for abnormalities of thyroid function, which interestingly are actually more common in people with Parkinson's disease. So that means having those blood tests, a really proper workup with your GP. And then looking very carefully at the medications, and this is where liaising with your neurologist is very important, to think very carefully about the potential for non-motor fluctuations and a wearing off effect, such as, for example, anxiety being worse in the off state or mood being worse in the off state, because sometimes there's interventions that with the dopaminergic medication that can help to address that. Avoiding alcohol and other factors that might be contributing to depression is also very important. So once we think about those biological factors, then we need to think about strategies that will have enduring benefits to manage depression and to manage anxiety. And psychological therapy can help to manage depression. There's evidence now to show that cognitive behavioural therapy is helpful. And I'll talk a bit more about what CBT is, but it's very useful to think about adding some of these tools to the kit bag, because they can be helpful for managing depression in the longer term. So some of these interventions like cognitive behavioural therapy will have enduring benefits, whereas a medication will only have benefit for depression whilst that person's taking the medication. And combining CBT with an antidepressant may be a more effective strategy than medication alone. So what is CBT? Cognitive behavioural therapy. It's a time-limited structured therapy that's delivered normally weekly over 10 or 12 sessions, and it explores how the thoughts and beliefs that we have influence how we feel and how we behave. So, for example, we may have developed unhelpful thinking styles or automatic thoughts, such as a tendency to catastrophize or a tendency to jump to conclusions. And those thoughts, how we perceive things, those thoughts influence how we feel and how we behave. So if we can better target those thoughts, if we can gain more insight into our patterns of thinking, we can actually change some of those automatic thinking styles. So it also involves learning techniques to challenge automatic negative thoughts and cognitive distortions, and particularly using behavioural approaches as well. And I'll come back and talk a bit more about this when we touch on anxiety management. In terms of behavioural activation strategies, there's evidence for scheduling in regular social activities, physical activities and pleasurable activities. So one of the things that happens with depression is from a behavioural point of view, when people develop depression, their energy is sapped. They don't get enjoyment from things that previously would have given them pleasure. So a lot of people will stop doing the things that previously they would have enjoyed, and it's very hard to socialise, so people tend to isolate. But then what happens as we progress around that cycle of depression from a behavioural perspective is we stop exercising, we stop our regular pleasurable activities, and we do start to isolate, which then leads to us becoming physically deconditioned. It leads to an erosion of our self-esteem, and then as we isolate further and further, and that person calls and we let the call go through to voicemail, And that cycle plays out over weeks and months. Eventually, the guilt sets in, and that further fuels the depression. So we can change that behavioural cycle of the depression by scheduling in activities, and using a written framework for that is helpful. So actually thinking about a written plan for the week, so writing out the days of the week, and setting some specific written goals can be very helpful. And one of the things when we ran through the neuropsychiatric symptoms or non-motor aspects of Parkinson's, apathy is a very important feature of depression. It's a very important feature of depression, but it's also a very important symptom in Parkinson's that can occur independently of depression. So given apathy is so prevalent, it's important to think about how we can schedule in things in a much more structured way to counter that. So apathy is where we don't initiate things as we previously would. So having a written framework for setting goals that are specific rather than non-specific. So rather than, say, if we're trying to improve the amount of exercise that we're doing, rather than saying next week I'm going to do a bit more exercise, can we be more specific? Can we say next week I'm going to aim to go for a 10-minute walk 3 times? If we can measure that, that's even better. And it's important to start with very achievable goals and then gradually push the boat out, rather than aiming for goals which are overly ambitious and then feeling that we've failed to achieve those. If we can think about why it's relevant for us to set those goals, that's really important, and it improves our likelihood of achieving those goals. So so think about why that is relevant for you, and having a time frame around this. It might be a time frame for goals for the next week, and then once you get beyond that, thinking about goals for the month ahead, etc., etc. And what naturally happens with depression is, as that person lifts out of depression, the horizon will stretch further out. Exercise is also a very important intervention, and we're going to be hearing more about this in the afternoon. But exercise plays a key role in managing mood and non-motor symptoms. And I'm sure there's going to be a lot of discussion about this afternoon. But there is evidence that exercise can alter the trajectory of Parkinson's, and that's very psychologically empowering. Okay, so rather than feeling that we're passively experiencing this condition, to feel that we have some way of modifying that trajectory is very empowering. And there's a study that came out a couple of months ago that showed that people who were allocated to higher intensity exercise compared to those who did moderate intensity exercise or no exercise showed a slower rate of progression in their Parkinson's. There was that study by Schenkman and colleagues. And that higher intensity exercise was looking at maintaining the heart rate between 80% of their maximum, which is 220 minus your age, and 80% of that figure. But at the end of the day, any exercise is better than no exercise, and there's a lot of other benefits for exercise. This study was looking specifically at progression in Parkinson's rating scores, but it's important to remember that exercise is very useful for managing mood and also for reducing the risk of longer-term dementia. So exercise, in the same way as we think about prescribing an antidepressant or prescribing a medication, we really need to think about prescribing exercise and having that in the weekly plan. And then it's about working out what the individual can do that's safe and is feasible to build into the week. Now, moving on to medication strategies to manage depression, we spoke about how, since we can lose neurons that produce serotonin and also neurons that produce noradrenaline, are there ways that we can increase the availability of serotonin and increase the availability of other neurotransmitters like noradrenaline? Well, the answer is there are, and SSRIs are selective serotonin reuptake inhibitors, and they're considered to be the first-line medication treatments in Parkinson's. Sertraline, so there's a number of SSRIs. Sertraline is one of the ones that's been most widely studied, and it's been shown to improve quality of life, activities of daily living, and even mobility. Coming back to the point that if we can treat an underlying mood disorder or an anxiety disorder, we can actually improve motor function. The absolute risk of worsening motor symptoms with an antidepressant is actually quite low. So in terms of with any treatment strategy that's proposed, you need to weigh up the risks and the benefits. But there's a considerable benefit from using these treatments, and the risk of worsening motor symptoms is relatively low. There are obviously antidepressants which are statistically slightly more powerful than the SSRIs, but such as the tricyclic antidepressants, the older style antidepressants, but they tend to be less well tolerated due to their side effect profile, particularly around constipation, dry mouth, urinary retention, impaired cognition. They can also lower the blood pressure on standing and increase the risk of developing a irregular heart rhythm. So everyone's situation is unique, and this is where you need to weigh up the relative pros and cons of an antidepressant strategy and talk that through with your doctor. And also your neurologist. So we know now that dopamine agonists can potentially be helpful as well for treating depression. So pramipexole, for example, can sometimes be used, but once again, it's weighing up the risks of things such as impulse control disorders and other associated side effects that can occur with that strategy, with the benefits. And there appears to be a dose-response relationship with that as well, with some of those impulse control disorders being more common at the higher doses, whereas lower doses can often be helpful for improving mood. There's good evidence for other classes of antidepressants as well. So venlafaxine, which acts on serotonin and noradrenaline. And apathy is the other feature, which we said can occur as a feature of depression, but you can have apathy separate to a syndrome of depression. So you can have a patient with Parkinson's disease who doesn't have a syndrome of depression, but they have significant apathy. And there's good data that this is very common and it's very debilitating, up to 40% of patients in one study. And there is a dopaminergic hypothesis around that, where if we can increase the availability of dopamine, that can sometimes help with apathy. The data around that is somewhat inconsistent, though, so that strategy is not always effective, but it certainly is something to review closely. And there may be a role for treatments which might be in place to manage Parkinson's related dementia that may provide benefit as well, such as rivastigmine. Now, moving on to anxiety disorders. Just looking at the time. So anxiety disorders occur in around 20 to 30% of patients with Parkinson's disease at some stage in their illness. So very common conditions, and it's important to educate people around someone with Parkinson's that there's a real difference between anxiety, which is a normal emotion, and an anxiety disorder, where that person's fear circuitry is not working as it normally would. And we can conceptualize anxiety disorders in a number of different subgroups. Generalized anxiety disorder is essentially where there's an excessive level of worry. Social anxiety disorder is where we fear being judged negatively in social situations. So that person who has a fear of being judged negatively because of their tremor, who avoids going out because of that. Specific phobias and panic disorder. There is a wearing off hypothesis that can account for anxiety in a certain percentage of people. So that's where in the off state, people, as well as feeling lower in their mood, are also more likely to experience anxiety and panic. And in that elevated state, or in the on state, anxiety resolves. So coming back to this slide we showed beforehand, really trying to carefully map out that relationship between anxiety and the off state is important, because if there is a relationship, that is something that your neurologist and your psychiatrist can work closely to address and potentially better manage. And this is one thing we see after DBS. So So DBS smooths out that on-off, those on-off fluctuations after the surgery, and as we smooth that out from a motor perspective, we also smooth out the non-motor fluctuations. So that's why anxiety overall improves in patients after DBS, as there's a reduction in those fluctuations. In terms of treatment for anxiety disorders in Parkinson's, in a similar way with depression, we need to exclude physical illness. We've spoken about thyroid disease. That's particularly relevant with anxiety. If the thyroid's overactive, that can cause an anxiety disorder. We need to address drug and alcohol use. So alcohol acts on the brain as a depressant, and it can actually increase anxiety. So really paying attention to that, and then thinking about treatments that have enduring benefits. So we know that CBT has been shown to be effective, and it's important to incorporate a behavioural plan to target anxiety. So the B in CBT, the cognitive behavioural therapy, involves actually challenging some of those situations that we do fear. So say if someone has a fear of social situations and they're avoiding that, to really address that social anxiety disorder, we have to avoid avoidance and get that person to gradually confront some of those situations that they fear, starting off with something that's mildly anxiety provoking and then working our way up to more and more anxiety provoking situations. We need to increase exercise and really trying to build that into the day is important. We need to think about mindfulness techniques, and I'm going to come back to focus on that in more detail. And we need to think about commencing an antidepressant. So we refer to them as antidepressants, but they're actually licensed for anxiety disorders. We look at sertraline. And whilst they can take some time to kick in, so it can actually take an antidepressant 2 months to have its full anti-anxiety effect, those antidepressants are actually very effective in treating an anxiety disorder. So we certainly need to really consider using such a medication, and thinking about avoiding things that might make things worse. So benzodiazepines, things like Valium, are very tempting because straight away they will take care of anxiety, they'll reduce anxiety, but they can exacerbate they can worsen cognition, they can affect motor function, they can increase the risk of falls. So whilst benzodiazepines do have a role in managing anxiety, we really need to think very carefully about that risk-benefit ratio, and generally we can avoid benzodiazepines. So coming back to mindfulness, mindfulness is another useful tool in the kit bag. There's good evidence now for mindfulness training in Parkinson's patients, and there's a whole wealth of evidence for mindfulness training in better managing anxiety in patients who don't have Parkinson's. And interestingly, some of these studies, although they're quite small studies, this recent study of mindfulness training in Parkinson's patients did actually show an improvement in motor scores as well, which reflects that concept that as we bring down anxiety, it can actually improve tremor control. There's also been very promising qualitative study data, and I'll talk about that qualitative study in a minute, but just to flesh out this concept of mindfulness. Mindfulness is not a new concept. It's actually a very old concept. It's a central tenet of Buddhist practice, and it refers to focusing our attention on observing oneself or one's immediate context through describing rather than judging experiences. So external experiences, internal experiences. Mindfulness is about fully participating in the experience and focusing our awareness and assuming a non-judgmental stance. So to summarise, it involves focused attention. So for example, keeping the focus on our nostrils as we do that slow, regular breathing. And it involves open monitoring of our thoughts. So it trains that non-judgmental awareness. And in healthy people without Parkinson's and without any mental disorder, mindfulness training has been shown to improve attention and to improve working memory. And I'll talk about one study that showed that these were in healthy volunteers who didn't have Parkinson's, or indeed people who didn't have a mental illness. It was just looking at healthy volunteers and looking to see what changes happen in the brain. So this study by Allen and colleagues took 61 patients and followed them through a course of mindfulness training, and people were doing 2 hours a week, and they were doing this for 6 weeks. And then there was a control group that was doing a control activity. I think it was actually listening to an audiobook of Jane Austen's Emma. Anyway, they followed the group, and they showed that the group who did mindfulness training showed better performance on cognitive testing. So this is a study called the Stroop Test, where you get people to name the colour. It's obviously easier in the first set as opposed to the second set, where we have to work harder because the colour doesn't match the word. And looking at this study here, they showed that as people spent more time practicing mindfulness, they actually got better at recruiting this area of the brain called the insula, which is this region here. So that's a bit of a busy slide, but the point behind that slide is that mindfulness training does bring about a very real change in our fear circuitry. It's not just psychobabble, it actually brings about a real change in how our brain functions. And it's something which is able to be incorporated into our daily lives, which can actually help with managing the symptoms of Parkinson's. So this is coming back to talk about this qualitative study that I referred to beforehand, which was a study by Fitzpatrick and colleagues, where they really sort of drilled down and looked at patients' experiences. So these were patients with Parkinson's who underwent a mindfulness training course, and they showed that patients who did that mindfulness training, they experienced decreased anxiety, they experienced better pain control, greater self-awareness, improved well-being, and most importantly, better acceptance of Parkinson's and less avoidance of social situations. And this is a quote from one of those participants. Andrew was a man with Parkinson's, who said that a lot of what happens to a Parkinson's patient is exacerbated or can be exacerbated by stress and emotions. So if you can control is the wrong word, if you can ride with them, then it can be better for you. That was his way of describing, which I think is a very, very neat way of conceptualising how mindfulness can be helpful for better riding out some of those on-off fluctuations and those really distressing times when we are in that off state. So thinking about mindfulness is well worthwhile. CBT is still the gold standard, but both those approaches are worth having in the kit bag for managing anxiety. And they're things that you could cover with a psychologist, with a psychiatrist. You could even do some mindfulness training online. The Headspace app, there's a whole range of different apps that you can use these days. But if you're interested in exploring that, you can trial some of these apps, such as the Headspace app, for free. So I'd encourage everyone to think about that. And just in terms of sleep disturbance, so sleep is a whole talk in itself, and I'm just going to touch on sleep very briefly because sleep does impact on the next and final topic, which is hallucinations and psychotic symptoms. So sleep disturbance in Parkinson's can include insomnia and nightmares. It can include excessive daytime sleepiness and sleep attacks. It can include a REM sleep behavioural disorder, that acting out of our dreams in our sleep. It can incorporate restless leg syndrome and periodic leg movements. And that's just a reminder about where REM sleep comes in, where we can, particularly in the later stages of sleep, in the early hours of the morning, where we can experience those problems, where we experience loss of paralysis in our sleep. And some medications can be helpful for that, and improving sleep can actually improve the management of psychotic symptoms. And there's quite quite a complex relationship between sleep disorders and hallucinations. We don't have time to really focus on Lewy body dementia, but REM sleep behavioural disorder and its association with that condition later in life is an important association that's receiving a lot of focus. But improving sleep can improve the management of hallucinations. So we really need to think about sleep when we're managing hallucinations. And psychosis in general tends to normally be associated with visual hallucinations, so seeing things that aren't there, rather than other modalities of hallucinations. So we can experience hallucinations in other modalities, such as sensory hallucinations, hallucinations of taste, smell, but visual hallucinations are the most common, and generally people experience visual illusions first. So an illusion is where we misinterpret something. So I misinterpret this object here, and I think that it's a dog. That's a visual illusion, whereas a visual hallucination is where I see something and there's nothing actually there. So these visual illusions are often tend to progress to benign hallucinations, which are benign in the sense that that person can rationalise that, they can register that there is no dog there, they're just misinterpreting that object. And as long as they're not distressing, we don't necessarily need to treat hallucinations. So that's a really important point. Education's really crucial. Educating a partner and educating that patient about hallucinations, because we don't always need to treat that. However, sometimes hallucinations can progress into more frank psychosis. And psychosis is where we develop delusion. So a delusion is a fixed false belief that's not consistent with our culture. And psychosis and dementia very frequently coexist, and having one predicts the development of the other. And as we referred to beforehand, sleep disorder is associated with an increased risk of psychosis. So dopaminergic medication plays a key role in causing psychosis, in addition to the illness alone. So certain medications are more likely to exacerbate psychosis or exacerbate hallucinations and delusions, and we can rationalise some of those medications sometimes to improve psychosis. So anticholinergic medications and dopamine agonists tend to be associated with a higher risk of inducing psychosis rather than some of the other treatments such as levodopa. But psychosis is certainly a major source of caregiver distress and early death, and it's the leading cause for institutionalisation. So really paying attention to optimising the management of psychosis is important. And the first thing is to exclude a delirium, so a temporary confusional state that may be due to other causes. So, for example, someone has developed a urinary tract infection and has developed a delirium. It'd be important to exclude that isn't the case, because if that person does have a urinary tract infection and you treat that with an antibiotic, we'll see that delirium resolve and those psychotic symptoms resolve. Optimising the environment and educating the caregiver is really crucial, and really thinking carefully about the risks versus benefits of an antipsychotic treatment. The first and easiest step is to consider reducing or stopping medications, particularly things like anticholinergics, and seeing whether we can rationalise some of the medication. So that's where you need to work very closely with your neurologist. And there's a standard order of elimination whereby we start off with the anticholinergic medications, and then we might stop Symmetrol if that person's on that medication, and progressively work our way down as much as is safe for that patient to still provide adequate motor control. So once we've done all that and we've ruled out things and we've rationalised the medications, and that if that person still has hallucinations and psychotic symptoms, then we can think about starting an antipsychotic treatment. And the first choice is normally quetiapine because it's best tolerated of all the atypical antipsychotics. It's not a foolproof strategy, and there are some negative studies, but there is often some benefit from quetiapine. But far and away, the most effective antipsychotic medication is clozapine. But clozapine involves a much more involved process of commencing. It requires weekly blood tests for the first 18 weeks, just to rule out or to exclude a complication that can occur with clozapine, where it can affect white blood cells. So that's quite an involved process. But if someone really does have distressing psychotic symptoms, clozapine tends to be underutilised because there is so much rigmarole with starting it. So advocating for clozapine is important. And the risks of antipsychotic medication also need to be considered. There are risks with antipsychotic medications, including cardiovascular risks, metabolic syndrome risks. So we need to really carefully weigh up that risk versus the benefit. And considering a cholinesterase inhibitor is very important, especially if there's comorbid dementia. So there's good evidence for starting a cholinase inhibitor, such as the Exelon patch, if someone has that overlap of dementia and psychotic symptoms. And we're coming to an end now. These are some resources which I think are really useful. So one is a pamphlet from Parkinson's Australia, the DASH handbook, which you can also access online as a PDF, and that covers. The DASH stands for depression, anxiety, sleep, and hallucinations, and that's a good overview of some of these symptoms. There's a DVD you can get from Beyond Blue that looks at depression and Parkinson's. And we spoke about some of the mindfulness resources, the bookshelves that DMICs are groaning with books on mindfulness these days. It's very much become a bit of a buzzword. So there's lots of resources out there. This book, The Happiness Trap, is a particularly useful book by an Australian, particularly when it comes to acceptance and using acceptance for managing a condition like Parkinson's disease is very useful. And finally, Carers Australia.